Um, so I am very pleased to introduce a dear friend and colleague. Essie is a third-year medical student at UIC. They majored in gender and women's studies at Dartmouth, pretty fancy. Um, and they have been very active in queer and trans circles for a long time, since high school, and in medical school have continued their work around racial justice and queer justice. They have aspirations of becoming a plastic surgeon and reimagining what gender affirming care looks like. We are really excited to hear their talk on medicalizing queerness. So without any more ado, I will turn it over to them. Welcome, Essie.
Thanks so much for that lovely introduction, Peter. I'm really glad you used this, like some other choice words. So hi everyone, my name's Essie Ghafoor. So before we get started, so yeah, this is the talk, Medicalizing Queerness, Medicine as an Institution of Social Control. And this presentation was put together by myself and the Garg. So I think just since the group's so small, before I go into like my other things, let's just like go around and do names and pronouns. And if you have any access needs, because there's so few of us, we should do that. So yeah, Essie, they, them. My access needs are met. You might be seeing me like go over here because this is where like my other screen is, where I have the slides and things. And so yeah. Whoever would like to go next can go.
I can go. I'm Maya, she, her. My access needs are met.
I'm Peter, he, him. I will have to step off at 7:30, but otherwise, I'm here.
Hi, I'm Sam. I use she, they pronouns, and my access needs are met, and I'll have to leave a little bit early too.
I think that leaves me. I'm Harshita. Pronouns are she, her. I might have to leave early as well, but hi.
I think we just one more person just came in, I think. Oh, hi Lily. We're just doing names we're just doing names, pronouns, and any access needs. And then if your access needs are met, you just like my access needs are met.
I can turn my video on. Yes. So I'm Lily. My pronouns are she, hers, and I don't think I requested any access needs for the presentation today.
Awesome. So that's everyone. Amazing. So now we'll get started. All right. So yeah, just like the general introduction, Essie Ghafoor. I put all of these here. So identify as queer, trans, feminine, non-binary. I am Black, as you can probably see from this lovely melanated skin. I'm middle class, able-bodied, and neuroatypical. And the reason why I list off these is to really like provide context for like how I conceive of like the world and society, and like how I navigate all of it, right? Like how the things we identify with and like how we live our lives deeply influences and like colors how we think of and see everything else. And so positionality is a really important thing to think about when you're thinking about how you think about, you know, medicine and other huge things that have impacts on our lives. Okay, so we have our outline. Yeah, so we did some introductions. We're gonna go to some working agreements, get some like common definitions, go through a little bit of history, talk about some medical gatekeeping in the 21st century, and then we're gonna sort of conclude, sort of like put all that into action by thinking about some cases, some of which are actually happened. So yeah, let's get started. All right, so some working agreements. So ground your statements in personal experience, use I statements because no experience is universal. Everything we share is confidential. Take what you learn, but like leave names and personal stories out of it because you want to be mindful of that. Be mindful of the space that you're taking up. This is particularly for white folks, like white folks and men. as his folks, just think about like how much space you're taking up and like who is not talking, right? And so we can make sure that we're hearing folks' voice who may be often silenced in other spaces. And be respectful. And that's kind of hard. Like respectful is always kind of hard because like what does that mean, especially when you want to try to divorce yourself from respectability politics. But basically just like try to not be awful. So do folks can we just like get do folks agree to these agreements? I can show like a thumbs up or in the chat. You can I can't really see all of you, so if you nod, I might not see you, but you can also just put in the chat. Thank you, Peter, for the thumbs up. Amazing. Awesome. I can't see other folks. Okay, does anyone have anything they want to add before we move on? Okay. And also it's like a living document, right? Like it can change as we go. So to start off, how does medicine, right, affect other institutions? So in this question, I'm asked, just so you're not like trying to guess what I'm thinking, like as I think a lot of us are asked as medical students, like when I'm thinking really globally, like how does medicine affect like the law? How does medicine affect religion? That's sort of like the level that I'm thinking in this question. Yeah, so feel free to speak up. Feel free to like write your response in the chat, whatever feels good for you. I'll give folks like a minute, just like a few seconds to think. Any takers? So if we think about medicine, right? Like how does it influence trafficking? How does medicine influence education?
Sorry to interrupt.
Yeah.
Are y'all able to message everyone in the chat, or is there a setting I should change so the chat works better?
Oh, if you want to put things in the chat, because I haven't seen anything. Yeah, right now I can only message you, Maya.
Okay, I'm gonna try to deal with that. Sorry about that.
It's okay. Did some folks put some things in the chat that I can't see? Oh, okay. I was like, okay.
So to your question, Essie,
Yeah.
I think like medicine is viewed as something that's objective or portrayed that way by these other institutions. Mm-hmm. And so it sort of gives this objective or scientific cover to the statements or definitions or conclusions that it draws. So for example, that in education is it might say that ADHD is a real thing. So you get testing accommodations if you have ADHD.
Yeah, that's a really good point. Yeah. Anybody else?
I guess
Yeah.
this question makes me think of medicine's connections and like mutual reinforcement with the criminal legal system. Mm-hmm. And I guess the first thing that comes to mind is just how similar psychiatric incarceration can be to incarceration through the criminal legal system and how interconnected they are. And how certain folks and certain experiences are pathologized, and that leads to heightened criminalization and policing of some people over others.
Yeah, thank you so much for that, Sam. That's a super great point. And then moving on to the second question, like how is medicine affected by other institutions? Okay, I'm gonna leave it at that because that's what we're here for, right? So we're gonna talk about it. We're gonna talk about it a bunch. Okay. So I just want us to go on the same page on some just kind of basic definitions and just make sure we all agree on them. So like when we're using language, we all know what each other means. Next slide. Cool. So norms. The rules or expectations that determine and regulate appropriate behavior within a culture, group, or society. They can be formal or informal, right? So when I think about norms, I just think about right now a norm is hopefully is like folks are walking around with masks on, and like if you're not, someone probably is judging. So that's like a norm, right? That like some places have made it formal, some places it's more informal. Do folks agree on this definition? And then if you want to add things, just like let me know as I go through them. Deviance, right? So meaning given to an act, belief, or condition that violates a norm that is negatively valued by society. And then specific definitions of deviance are socially constructed relative to actors, context, and historical time. But so honestly, when I think about deviance, I often think about how that's kind of like the first way that something is othered, is it's usually cast as being deviant, right? Because it's like, this is not what the norm is, it's like separate from that. And it always seems like the first path for when I think about how something, some idea, or some identity is othered. Socialization, the actor process or an individual or group learning the expected norms and customs of a group or society through social interaction. So for socialization, I honestly think the most about just like our education system and how that like grooms us to be able to be helpful in like this like capitalist machine and like be like what are considered like productive like citizens, right? And have us like think in a very specific way that really just reinforces capitalism. Anyone want to add anything to the idea of to our definition of socialization? No? Okay, next slide. Okay, hegemony. So the authority, dominance, and influence of one group, nation, or society over another group, nation, or society, typically through cultural, economic, or political means. When I think about, honestly, I use hegemony, honestly, I never say this word. I mostly use it in terms of like, to describe something. So I think I talk a lot about like hegemonic masculinity, which is like the dominant conception of what masculinity is. It's particularly like in the West, like in the US, right? That's usually how I use it, right? Like what's like the dominant idea of a thing, right? Like I wouldn't say that US hegemonic masculinity involves picking flowers or like, yeah, like we're like putting flowers in here. Like that's not like, that's a masculinity, but just not hegemonic, right? And then these last two, institution, a large scale social arrangement that is stable and predictable, created and maintained. I actually like this definition. I particularly like that it like has this idea that it's created and maintained, which is sort of an idea that we're gonna be talking about today. And lastly, social control is maintained by institutions that are capable of defining deviance. And so like education, religion, law, medicine, us, like, yeah. Anyone who want to add anything to our definitions? Do they seem good? Thoughts? Great. Moving on. Okay, we're gonna talk a little bit about history, right? Because like I think that history is really important, thinking about what moment you're in, like in time, like because oftentimes like history just kind of happens again. And I think it's really important to just the verb I always use like historicize, right? Like think about our current moment in context of what history tells us. So next slide. Okay. So when I think about, I'm gonna say queerness because whenever I say homosexuality, I kind of like it's like painful. So queerness, right? Like really started out as being conceived of as a disease, right? And that kind of started like you can trace that back really to like the late 1700s. And so that's just sort of like the starting point, is like something being, which is like actually kind of interesting, right? That it didn't really start out just being deviant. It started out straight up, this is just a disease, which I think is like an interesting way for a place for something to start. Although, let's be honest, before that it was probably also considered deviant. So yeah. So you have, moving forward, you start seeing in the early 1900s with this committee, people talking about the rights of homosexuals, right? Whereas this idea of like, even though it's a disease, we still should probably advocate and like think about that these people are still human. And that really brings up for me this idea of like who defines like who's a human, right? And like who deserves to be treated as such, right? Whether or not you have a disease or don't. And so that's kind of like our starting point, right? Is like, is disease, it's a sin, these sort of ideas that are sort of based in medicine, but also in religion. Next slide. Cool. So you have scholars challenge APA about this idea about it being a disease, right? But you also have the APA adding homosexuality to the DSM in 1952. And the DSM, right, is this, for anyone who doesn't know, it's just like the manual that is mostly used by psychiatrists that like lists all the mental health illnesses that we think are real. And so what's really interesting and important to think about when you're thinking about this shift is like, this is like what everyone uses to refer to like what's an illness, right? Like there's like before it was this like societal concept, right, of like it's disease, and maybe it was written in some textbooks that no one was reading, but like this is like a manual that everyone's using, and so to add that like adds a legitimacy to the pathologization of homosexuality that I think is different than where it was previously. So Evelyn Hooker's noted here that there was like, was the first person to do research on homosexuals outside of prison. A lot of the research was only folks that were in prison, which is just as like a research metric doesn't really make sense in terms of like how are you going to get like good information from a population when you're looking at a population within another very specific population. That's a whole thing. And then of course, in like you have like the Kinsey studies here, which illustrated this variance of sexuality outside of this binary of being homosexual or heterosexual. As I'm going through, just like you've questions, thoughts, things you want to add, because I don't know all the things. Was most of this regarding cis men? The Kinsey studies?
Yeah.
That's a great question. Don't know the factual answer, but probably yes. Almost probably yes. Okay, we're gonna go to the next slide. Another slide. Yeah. Oh, I lied. That was the slide that I wanted. Sorry. Okay, so pre-Stonewall, and during World War II, we see this where homosexual folks discharged dishonorably, and they're sort of connected to like the Cold War's Red Scare. So you see this like homosexuality being also cast as like this political entity alongside of it being pathologized and othered, which is pretty on brand, right? Like this is like other institutions, other ways that we think about and move in society, right? Like casting homosexuality as bad in some manner, and then acting on it, right? And so, oh, homosexual bad, this is bad, I'm going to associate these two to like maintain this characterization of this identity. So Christine Jorgensen's first known gender affirming surgery is thought to be like the first transgender celebrity in the US. So that's really notable. And then we have in the 1950s and 60s, you start seeing organizations sort of form that are like talking about building community and advocating for queer folks. And that's great, amazing. We love to see it. This is the one I wanted to go through. Next slide. Yeah, so that slide is really just getting at this question of like, what is the problem with single identity politics for the room? Oh yeah, it wasn't. That was not rhetorical. Sorry.
Can you
Yeah.
repeat or restate the question?
Yeah. Just the question was like, what's the problem with single identity politics?
I guess one problem is nobody lives a single identity life.
Yeah, right. Like none of us do. We're all like a universe of things, right? And so you can't like consider one thing without considering them all. And so that was what last time we were talking about, like just thinking about like, how do we go beyond single identity issues. So this is just sort of like a laundry list of things that occur. So APA keeps homosexuality DSM-2 in 1968, removes it in 1973 in the DSM-3, and replaced it with sexual orientation disturbance. No comment. Virginia Prince coins the term transgender in the 1970s. And then in 1980, the APA adds gender identity disorder and like defines treatment as surgery and forced socialization with like forced, okay, interesting choice of words for children. And what's interesting about this is that like transness had like continually been medicalized, and like still is now, which is like the thing we'll get to. But it's interesting about like what does it mean for like now homosexuality is out of this book of mental illnesses, but did that change anything in terms of how queer folks were like existed or being treated in society, not only by medicine but by the state, by all the other structures that we all live under. Next slide. I'm attempting to read the like small thing. So yes, I'm pretty sure. But this is pretty early. Like this is back before like I think like puberty blockers and like all the things you can do to sort of shift things were an option. Yeah. And I think it was thought to be more of a like parental choice. I think it was thought of like parents get to choose for this child for now. And that in theory, the treatment will be surgery when this person's an adult and can make the decision themselves. Was thought to be and yeah, I mostly you can see that when you mostly see that like playing out for intersex kids, I think. Yeah. Or at least that's how I know how to answer that question. Okay. Oh, we're already next slide. Yes. Right. So you can't really talk about queers without talking about HIV and AIDS, and so, but like, because this was like, okay, I shouldn't frame it positively, but like, when you had with AIDS, right, it provided an actual disease that could be really easily associated with the queer community, and this moment I feel like really epitomized how queerness was still thought of as an illness, because societal ideas, the state, medicine, I feel like everyone was ready to just ascribe this to the queer community, and because of that, didn't really do much to try to combat it, kind of until the case of Ryan White, which I think we reference in the next slide, that it really wasn't until this, I don't know if y'all know the case of Ryan White, it's basically like this little white, I should not laugh, but like this little white boy like got HIV from a blood transfusion, and everyone was like, oh my goodness, we have to do something because that's awful. And like, what did it mean? I get like what did it mean for that to be the moment when it had been ravaging the queer community for years at that point? But this one child gets it, and it's now like we have to pool all our resources to do something. And this really goes back to like the original thing I was posing earlier, like who's a human right? Like, who deserves care? Like, who deserves like interventions when something awful is happening to, when something awful is happening? Like, what communities is the state going to rise up to help defend and protect? So in this moment is where you're, sorry. Yeah, so in this moment is really where you see sort of this like a really clear integration of like religion, medicine, and the state all being like, yeah, queer people are the worst, and we're gonna do the bare minimum, if anything, to support them and keep on moving, which is really awful and sad. And to be honest, like a lot of people died because of that. How, right? Like that. Like that was not like a. It's not like that. Like that inaction didn't have consequences. And I feel like we all can say the same thing when we think about things like aspects of how this pandemic has played out, right? Yeah. So yeah, next slide. So yeah, these are some more for like trans stuff. This is more recently, 2013, APA changed gender identity disorder to gender dysphoria, which is still a hot topic within the trans community in terms of how we feel about that. And then 2019, WHO changed gender identity disorder to gender incongruence. Sure. And then we just have some time scales of just HIV treatment. So Sidovudine was approved in 1987. This case of Ryan White was in 1988. And in 2012, we see Truvada approved. And then in 2018, the CDC notes like the undetectable equals untransmittable, which still seems like people don't know, but okay. And then of course we have legalization of same-sex marriage, 2015. But I think something really notable and maybe slightly off topic, but I think everything's connected, is that how when we think about how the legalization of same-sex marriage, how that impacted like movement in queer, like the movement of queer like politics, like queer movement, right? Like, oh, like we can get married now, we're done, right? And like who's that for, right? Yeah, next slide. That's the slide. All right, so here we have a timeline that I'm not going to go through, but I will leave up for folks to read through our lovely labor, just to get a sense of like a more like, if you like visuals, this might be helpful. Next slide. And folks can get the recording, and folks can also have the copy of the PowerPoint after if you weren't given a chance to read everything that you wanted to. Next slide. Next slide. Trying to catch up on mine. Okay. Next slide. So the thing I want to know as we start to move to just a general question for the group is like queerness, like I'm not saying homosexuality. Queerness has like, it's not new, right? Like people didn't all of a sudden just start being queer, right? And so what does it mean for it to have taken this long, right? For us to be seen as human, if we even are at this point, right? I just want to like think about, right, like as we think about this like long timeline, right, that it's not like this like identity is like a thing that is only exists in the 21st century, which I think some kind of think. So yeah, and transness too, right? Like queer and transness like are not new things. Yeah. And what does it mean for both of these identity groups to have such a robust history of being othered by most folks, like most structures in the West? Okay, so next slide. So where else in history do we see medicine and other institutions working in tandem to shape our understandings of social issues? I can give an example. Yeah, I'll give an example. I'll give an example, and then maybe that will jog some people's thoughts. So when I think about this, I think a lot about race, partially because I did a bunch of research in undergrad around like early, basically the conception of biomedicine in like the late 1800s, early 1900s, like the standardization of like biomedicine as like how we were going to think about medicine in like the modern epoch era. I don't know, one of those words. So yeah, I'll give y'all a little hit of all of that, right? So if we think about biomedicine, right? Like when I say biomedicine, I mean like we know about like cells now, right? And like germ theory, right? That all of that was like being like recognized and thought about and like built in the same moment that like Black folks in the US were just getting out of slavery. Like they were happening, I think, like virtually around the exact same time, right? And like, what does that mean for how we think about medicine today? That the very beginning of it is integrated with like this country just getting Black folks out of slavery, right? And then still under like Jim Crow, still under Jim Crow, not it's not like they like hopped out of slavery and like things were great, right? So like, what does it mean for that moment and like all that scientific knowledge being created to be alongside the denigration and the continued denigration of Black folks just in a different way, right? So you saw a bunch of like medicalizing Black, you saw a lot of medicalizing Black just in general, but like even before slavery ended, you had diseases that were like, there was a disease for like slaves that ran away. I forget what it's called now, but there was like, they like made a disease for that, right? So like medicine was used as a means to like both justify slavery, right? Like to justify like enslaving Black folks, but also into treating them as subhuman for like, even after slavery was over. And you can sort of see that play out like throughout the late 1800s, like early 1900s, and sort of like continues. And you still see messages of that today. So that's just one example of how it informed how we think about Black folks, right? Like even like today we think about, I'm sure a lot of you heard that study a few years ago that where they asked medical students and residents about Black skin and about our like pain tolerance, right? Like, why did a bunch of people think that Black people's skin is thicker than white people's skin? That's directly from like late 1800s, early 1900s, like thought about Black bodies, right? And like why that's still here, right? And part of that is because that's when we were creating this like very, very small, granular like form of medicine that we continue to practice today. So that's one example. Yeah. Yeah, definitely. That's a really good point. Mm-hmm. Yeah, like who do you? Yeah, like how do you choose like who gets like put into it, like puts on a psych hold, right? And like who like I feel like, yeah, I feel like we can talk all day about this, right? Because like for substance use, there's just so much, right? And I think for medicine specifically, we think a lot about like whose responsibility is this, right? And I feel like really often in medicine, a lot of, or at least medicine has like, when we think about the entire institution, right, like tries to not be responsible for as little as possible. Because we're supposed to be like the neutral, objective ones. Folks have other thoughts about this? How does medicine, I'm just thinking of more specific things, how does medicine affect our understanding of abortion? How does that interplay with religion? Right? No one has to answer. I'm just like offering other things, right? Like how does it affect how we think about this is like, so trans folks competing in sports, right? Like how do we play a role? How do we play a role in that, right? How does the legal system play a role in that? How is that influenced by capitalism? Because it's kind of always the question. Yeah. And what does that mean, right? What does that mean for like your education to like bring in religion? And how does that change how everyone conceives of, right? Like what it means to care for someone, right? If it's roped into a specific religion, not even just religion in general, right? Like a very specific one.
I've been at the emergency department at county for the last couple of weeks, and there are other arms of state power in that space constantly. So we're always seeing either police there with people, corrections officers there, detectives there, Children and Family Services, Department of Children and Family Services there. And so there's just like it's an interface point with like sort of other institutions of state oppression, can kind of congregate in these medical spaces. And I think particularly about, like Children and Family Services as one where the sort of veneer of objectivity that medicine assigns to itself lets it kind of like wash its hands of the messy and oppressive like reality of the role that it plays, of who's fit to do this, like, who, why, and sort of also absolving itself of the questions of why social conditions are the way they are, and pretending that it can be neutral in that playing field when I don't really think that that's possible.
Yeah, medicine, like, that's a really great point. Thanks, Peter. Medicine tries really hard, right, to seem as objective and train us, right, to think of ourselves as being able to be objective and being able to make neutral ass decisions that like, aren't impacted by anything, right? And that's not how this all works, right? There's a reason why when someone like you were saying, like when someone comes to the ED, one of the questions we ask, right, is like, what's their insurance, right? So like that's like intrinsically a part of their care, right? Yeah. How I'm trying to think out. I think there's one more thing I wanted to bring up about this though. What was it? Prisons, right? Like how does we interact with inmates, right? Like patients from prisons come in, right, to the hospital, right? And so how does medicine influence our conception of just like imprisonment, right? Like I had a patient a bunch of months ago that was an inmate, and there were always 3 to 4 guards in the room at all times. And he was like shackled to the bed at both of his limbs, and one of the guards always had a gun. And like, I remember constantly thinking about like we allow that to like come into like our hospital and like allow a human to be like treated that way, even within like the walls of like our space, right? So like we are endorsing prisons, right? By being like it's totally fine for you to bring this human in here, have all these guards here, like have this person chained to a bed. That's totally fine. I remember the patient got into like an altercation with one of the guards because the guard like took some of his food, which like what, like why the fuck are you taking my patient's food? Like that's fucked up. Also, you have all this power over him. But like, can I do anything? Like absolutely not, right? So like, what does it mean that like we allow prisons to essentially function within our hospitals? Yeah. And what messaging are we sending about prison, about like how medicine conceives of prisons, right? We support them. Yeah. Okay. Next slide. Okay, so for content, I created this like pyramid to sort of guide folks into thinking about medical gatekeeping in like a sequential fashion. And so at the top here, we have just like societal norms, right? Then we have norms and practices of other institutions. Then we have organizations within healthcare. And then we have at the smallest level, like providers, right? About how like gatekeeping happens at each of these levels, right? And how that creates this huge barrier to care and how it makes it really difficult for queer and trans folks to access care, right? And to be treated appropriately, right? So what are some, hold on, I'm just gonna check the next slide. Okay, so this funnel really, and for the folks here, I feel like we all sort of have a sense of where this is going. So I'm actually not gonna spend, do you have questions about this? Does anyone not get it? Would it be helpful if I provide like one example for each thing? Would that be? Sure, okay, I can do that. So societal norms, right? When I think about folks often presume that, I think of a norm. Oh, okay. So yeah, wait, I'm pretending like I don't already have slides. Like, okay. So societal level, like since folks often feel entitled to the stories of trans folks, right? That's just sort of like whenever I meet someone, they always feel like they can ask me questions about my body and about like my life and then they act like I owe it to them to like provide clarity, which like, no. But then I see me and like I see like I'm doing too much because I don't want to tell you that about my genitalia. So that's like just like a societal like norm, right? But then also like people sort of always expect me to pass, even though I identify as non-binary. People often like expect me to be like, because I identify as trans femme as well, like I feel like I'm expected to look like a woman at all times, and like look as close to a woman as I possibly can, right? And that's like a like baseline expectation that like society sort of has of me as a trans person, even though I'm not a binary. I don't identify as a woman. I feel like societal norms haven't caught up to. Well, actually, I argue the societal norm for non-binary folks is that we're supposed to always look androgynous, which also is bullshit. So, and like not realistic and fucked. Yeah. So going down to norms and practices of other institutions, right? Let's see. I'm trying to like frame this in terms of my own experience. I think that's like the easiest way to understand it. Don't really want to do that one. Okay, yeah. Education system, right? I think, well, I went to high school in the US, right? I learned nothing about trans folks really in high school, but that like I feel like and like queer history like wasn't really taught. Like I feel like it was just this like pretty much erasure of like queer and trans folks as like this like lovely community that I could be a part of, where I could find all these friends. And so, but like, what does that mean, right? What does it mean to like not show me like representation of myself like in history, right? And like, but also like the U.S. education system is really just propaganda to like turn us into like folks that can maintain like this. I don't want to use the long word that Bell Hooks uses because I never remember it. Like I don't remember it. But basically, it's like to sustain the patriarchy, right? To sustain capitalism, to sustain all like systems of oppression that be is like what the point of like U.S. education, right? So, which does not include valuing right trans folks. Yeah. So organizations within healthcare. So I used to think about this differently, but now I think about this like, honestly, that you could really think about this is like, what EMR do you use, right? Like, did your EMR even provide and give people that ability to have a preferred name? That's not their legal name, right? Does it give them the opportunity to put their pronouns? Does it give them the opportunity to not identify as a man or a woman, right? And then like, what are the policies at that clinic, right? Do people, if there is a preferred name, do people even use it? If there are pronouns, do people even use it? Is there a policy to make sure that there are what's it called? If there are bathrooms for folks that don't identify within the binary, right? Like, it's funny how now I think about this a lot differently than when I originally made this PowerPoint, is like because I wasn't in third year yet. And now I think about it more of like a granular, like how does a hospital work? How does a clinic work? And how do those policies and regulations like impact and gatekeep queer and trans folks, right? In the waiting room, you know, they have those magazines that no one ever reads. Like, are there queer folks in these magazines? What magazines is there, right? Like what culture are you creating in a medical space, right? And then providers, right? This is kind of like where we all are, right? Is, do they know anything about trans folks, right? Do they know anything about queer folks? Do they know what questions are appropriate? What things are super not relevant, right? Yeah, so all of these things, right? Like create this like multiple levels of ways that when as a queer trans person, when you like are meeting the healthcare field, you like are constantly going up against, which make any encounter just a lot more fraught and negative than it should be. And also like we're the folks that get to make decisions about if they can access different kinds of care related to their trans identity for trans folks. Does that make sense for folks? Okay, so next slide. Right, intersectionality, which basically just means that like what we were saying earlier. I think it was Hannah that mentioned this. I think about how like like you can't like think about like one single identity. You have to think about all of them, right? So like when I walk into a doctor's appointment, right, I have to think about my trans identity along with my class. Along with the fact that I'm on UIC's campus care, which isn't really insurance, and so I don't have money. And that I am a medical student, and that which I think is my identity, but it's like relevant to like medical things, right? All these things, and my blackness, right? Like all these things are like exist in like are all present at once, and I can't just sort of pick one of how in terms of like this person's being trans because I'm black. Like it could be because I'm black, could be because I'm trans, could be because I don't have great insurance, like could be for a lot of different reasons, right? So I have this question like, what are some other systems of oppression that we have to account for? Right? So like I haven't really talked that much about like just like ableism, right? Like that's a thing, right? I haven't talked much about I haven't talked much about misogyny, right? Like all these ways, right, that the system oppresses folks, right? And that's kind of all that someone is like grappling with and navigating in really any environment, but there's something really heightened and specific about the medical encounter that makes having to navigate these things different. And like, what does it mean, right? That your patient, that your trans patient is constantly thinking about, is my doctor just thinking about what genitalia I have while they're trying to think about like why I'm having difficulties breathing? I'm pretty sure they're not related, right? And so, yeah, so as we move through our cases, do folks have, so before we get into cases, do folks have like questions, anything that's happened so far, thoughts people want to add? We're going through the first case together, so, no? So yeah, so as we move forward, I just want folks to just be trying to think as much as they can in this like multi-level like analysis, right? Like, how are societal norms affecting this? How are the norms of practice of other institutions affecting this, right? Like, how is the legal system affecting this? How is religion affecting this, right? How is education affecting this? How is like the specific organization within healthcare affecting this? And then how is at the provider level things being affected? To hopefully illustrate, right? The goal is to illustrate, right? How, like the ways in which all of these things function as it means to control queer and trans folks in a very specific way. Okay, so next slide. All right, so did folks have a chance to read the cases? It might not be case one because the order might be different, but did y'all read the case about Joanna Jacobs? If not, like one of us can put the link to the doc that has them.
I just shared it in the chat.
Beautiful, thank you. So while we, oh yeah, thank you, Maya, for bringing that up. So I'll give folks a minute to read this. So we sort of moved from like the lecture portion, which like, yeah. And so we're just gonna like talk about things, think about, and like try and be as critical as we can, right? And so this is going to be our starting point. Like, how do we take all this thought, right? How do we think about history? How do we think about how things exist, right? And how systemic pressures work? And apply that to real life things that can happen with our patients. So I'll give folks a minute to read. And then if we're done reading, if you could just like look away from the screen, then I'll know. Oh wait, that. Yeah, thank you, Sam. Okay, that only kind of works because I can only see some of you. So, did folks get a chance to read the case? All right, cool. So, what are initial thoughts?
I'm just kind of lolling at the image of Dr. Brigham stepping out into the hallway and pulling up the UpToDate app on his phone. And then, but that's an aside. It's off topic.
No, I asked for like, what are your reactions? Yeah, what, like, right? Like, we've like, most of us here have like seen a patient, right? Like, how do you feel about like, what was your like initial response as you were reading this?
I've heard or like seen attending physicians like ask about sex like in an awkward way and in a non-awkward way, and this like feels more awkward for sure.
Mm-hmm. Lily, did you have something? Okay, that's fine. Okay, so if you were Dr. Brigham, what might you have done differently?
I think that, and this is something that I don't know if I've ever seen done correctly, but like if you're the primary care physician who's talking to someone about their sexual health, I think you should always just inquire about specific sex acts, um, because you can be assigned female at birth and prefer penetrative anal sex and be at increased risk for HIV. Like that, it really has very little to do. I don't know. So that's what I would do is I would go through a list of specific sexual acts. There's CDC has an amazing website where you can like put in different sex acts and like types of protection, and they have enough data to like be able to gauge different risks of different, at least of HIV transmission based on the act itself rather than anybody's, organ inventory.
Yeah, that's a really good point. I want to know what happens.
I'll put it in the chat.
Oh, thank you. Yeah, when I think about this, well, I'll save my thoughts for anyone else want to. Oh. Yeah, definitely, right? Like just getting more information in general. Can we scroll down to the other questions? Yeah. So for our third question, what changes do you made in healthcare to reduce these kinds of doctor-patient interactions? Like, why did this happen? Do we think Dr. Bergman's a bad doctor? Do you think this moment that Dr. Bergman went out and got more information, do you think it was helpful? Because I think when I think about this, right? So when I think about this, right, I think a lot about what sort of information you folks get, right? Even about PrEP, right? And so I know that for at least my medical school, we talked a bit about it. And so like I think for those of us that are in school now, like we have been are familiar, right? But like for doctors that have been in practice for a while, do you think it's excusable that they don't know about it? Like if you're a PCP that just doesn't really have really many queer trans patients, do you think it's okay for that if they don't know about PrEP? All right, folks, we seem pretty quiet.
I think it's interesting. I don't know. It's kind of interesting that he had to step out and then look it up and then didn't ask her any follow-up questions, but I'm not contributing anything new than what everyone else has already said.
Yeah, did Joanna's transness matter? And if so, go ahead.
Can you repeat the question? I didn't catch it.
Yeah, like did Joanna's transness matter in this scenario? Like did the fact that she's trans like matter in her care? And if so, how?
I think I kind of agree with previous statements about just generally needing to collect more information about her sexual behaviors because like generally there could be a high probability of HIV if There's like different types of like activities, and so it matters, but it's not the most important thing. I think that Dr. Brigham should have just began with general questions.
Yeah. So, okay, so can we scroll back up to the case? So before we go back into the PowerPoint, I just want to be just a smidgen vulnerable, right? So this scenario like actually happened to me. I'm not Joanna Jacobs, but like, but because I'm not a white woman. So, but this didn't happen to me like at like with my PCP a few years ago, before I was in medical school, and I remember being just like, what just happened? I just remember being really confused about like what had just happened. Like, I remember feeling really frustrated that like I felt like I had to like educate her about this medication. Like this was pre-medical school, so it's not even like I really knew like what I know now, but I knew enough that like oh like here's what it is, blah blah blah. Here's where it might be indicated, and like she still had to like leave to go and look it up, and it's a really, really strange feeling when you feel like you know more about something than your physician, right? When you're not in healthcare at all, right? Especially for something that's pretty common and straightforward, right? It's not like I was asking about some really rare genetics and condition, right? It was just PrEP. Yeah, and so I just want us to think about like, what it means for doctors to not know things. But that's talking really to doctor level, right? Like how do you feel like this could have been just improved if the policies were better at the clinic? Like a lot of places now, I feel like ask like it's like if someone's on PrEP, right? Like they could have started doing that, right? They could if you're thinking about even bigger than that, right? Like are they even like what's their protocol even on talking about sex, right? In terms of both at the provider level, but also at the like above that, like what are the MAs asking, right? So there's still like structural things that you can embed earlier to sort of like flesh out knowledge that just like maybe isn't gotten in medical school, or like maybe isn't gotten in residency, and maybe just needs like folks just need more information. If organizations have structures that at least hint at directions and knowledge bases that they should have, that could right make a difference, right? Yeah, but let's like reframe back to the case. I'm just gonna go through some back. Can we Maggie, can we go back to the slides? Oh yeah, Bonnie, did you want to say something?
Yeah, just about that scenario.
Yeah.
I find it curious that Dr. Brigham is counseling somebody on STIs, including HIV, and doesn't know what PrEP is. That sounds like malpractice to me.
I mean, I was as surprised as you.
That's like talking about STIs and not knowing what a condom is. I mean, it's just so basic to, sexual health. So I am sorry that happened to you because it's ridiculous.
That is how I felt at the moment. I was like, this is absurd. And it's just, there were no words. There were no words but, and like some people brought up, right? Like, we did not have a conversation about like the kinds of sex I was having at all, right? Like, there was no, like, it was nothing. It was like, oh, this is not my lane. I'm gonna just defer to ID? What? Why are we calling? I remember because this was pre-medical school. I was like, I guess I didn't really have the same understanding about like consults, but even then I was like, why are you consulting infectious disease for something like that? Like, what's infectious disease gonna do? Like, I remember being really
Seriously,
confused.
it's not MRSA.
Right, like I don't get it.
You don't
I know
have C. diff.
no, there's no antibiotics involved. Like confusion. But that's what I was told. I was literally told to reach out to an infectious disease doc for more information. Yeah. But also like but also to your point, right? Like what's the follow through? Right? Like, why in my next appointment was she not like, oh, I read up on all this stuff. I talked to the other providers. I'm so sorry, like I didn't know more at the time, but I got that information and I can now provide that to you, right? Like, I think it's also important that we maybe not make space, but like recognize that like we're human and like we're all not gonna be up to everything. Like I know there are things that like I know I don't know tons about specific health concerns for undocumented folks. There are probably some things I just like could and should know that'd be really helpful that I don't in this moment. But it's still, the onus is still on me that if I get that in front of me, like as a provider, that I like work to educate myself to be able to do better for my patients in the future. Okay, so multi-level analysis. So now that we've talked about this case and sort of like got our mind thinking about like real life patients, right? Like, and before we move on to the other cases, I'll just look at the time. Okay, cool. So you can hit the next thing. So here's some just like societal norms, right? Because I know we were talking about that before in terms of queer and, so for this, it's really just trans folks, right? So I talked about not like hanging to pass, needing to be able to like give our stories to folks. And being marked as dangerous, I feel like even aside from my blackness, I still have to negotiate that even my transness is too palatable, right? And I feel like that's mostly seen through needing to, I have to be really kind about pronouns. Like, and then I have to give people a lot of space around pronouns. And when I don't, or if I were not to, I feel like I'd get a lot more flack, and like people would think of it, people would be worse about it. So that trans folks aren't worthy of respect, right? Like through pronouns or misgendering, through names, and that we are sensitive and demanding. Because our like existence sort of intrinsically challenges things within society, and some folks aren't comfortable with that, and you're not supposed to, right? The whole point of a norm, right, is that it's supposed to be what's expected and be what everyone does. And so when your very being intrinsically goes against that, it can like bring things up for folks. Which is why, like for me, like even just like walking down the street feels really dangerous. And I talk kind of a lot about how nowhere really ever feels safe. Yeah. Which is really secondary, right, to all these societal norms that are like placed upon me and my body. And so which of these norms, right, was Joanna Jacobs like under? Yeah, no problem. Yeah, you're welcome. Right, like, did she feel like she needed to pass, right? Like, did she feel like she couldn't be more forceful about, I mean, I guess now it's weird because now I told you it's about me, right? Like, so like in that moment, right? I did not yell at this doctor, right? I did not go off on her, right? And I thought about it. I did it, right? For like a multitude of reasons, right? Like, what does it mean that I felt like I had to be really respectful and appropriate and be really sensitive to this doctor who just didn't know, this white woman who just didn't know. Yeah. Next slide. And hit it again. And again. So yeah, thinking about norms and practices of other institutions, right? Bathroom bills, like workplace laws, right? How trans identity is like intrinsically criminalized, especially when you start thinking about like kids, right? Like there's so many school districts that are having arguments about bathrooms right now, and like, can you discriminate against someone, like an employee, for being trans? Like, can you fire them for that? Which is like a whole thing, right? Like, if I'm a business and I sell, I'm trying to think of an example. If I'm a business and I sell like erectile dysfunction medications, how do I feel about having trans men working there and like working with client, like potential buyers, right? Like if I feel like that might impact my business, right? Can I fire them for that, right? And like, is the law behind me, right? Yeah. So religion, right? We've seen conversion camps, right? And that's still like, conversion camps have not been like across the US, have still not been like cast as like wrong and awful, right? There's still places like conversion camps are still a thing. And just like general ostracism from community, right? Like religion is so often, right, about like morality, and queerness and transness is really often just like kind of seen as just this like immoral and like entity and being, right? And then lastly, education, just like I was saying, right? Our education system really just creates us such that we can perpetuate the very things that we're being inoculated with, right? And so I'm told as a kid that transness or queerness is bad. So then I don't want to both accept it for myself, but I also don't want to accept it in other people, right? And so I feel that's why even within the queer and trans community, you still see a lot of policing of folks because that's what we were trained to do. Next slide. Thanks, Peter. Cool. So Nordic practice of other organizations within medicine / healthcare. And so gender dysphoria is still in the DSM-5. I still feel like about it. when you talk to trans folks, you get like various opinions about whether it should be there, and that kind of loops right back into the idea like insurance, right? And that you need a diagnosis to bill for things, right? Like what is it like ICD-10? Like you need an ICD-10 code to bill for anything, right? And so if I can't give it a diagnosis, I can't really bill for it. I can't really give you medications for it then. And like, what does that mean, right? And then, especially when you want to start accessing like things like surgery, right? You need like, and we'll talk about this when we look at like some of the other cases, that you have to need a diagnosis or for some providers, you would need a diagnosis to be able to access surgery, right? And like, how does that remove like autonomy, right? And then just like lack of protocol. So like, I hear like WPATH stands for like the World Professional Association for Transgender Healthcare, and TPATH is just like Transgender Professional Association. It's just the same thing, just specifically for trans folks. And these organizations like try to like put together like guidelines for the care of trans folks, but we shall see them and see how great and useful they are. And then just like lack of provider education, right? Like how much are we educating current doctors, like those of us that are like medical students, like how much training are we really getting around queer and trans care? And like how is that training going beyond being like, don't be awful, right? Like how do you make sure that queer and trans patients feel safe when they're being cared by you and know that you're not just minimizing them to their genitalia or their sexuality? Next slide. Yeah, so like I was saying, like lack of education, broken arm syndrome, I sort of referred to a little bit earlier, where providers feel like they can just ask invasive questions. Like if I come in for a broken arm, why are you asking me about my genitalia? Like it's just not connected, right? Like I'm here for my broken arm, and providers sometimes, because there's this like, oftentimes I feel with cis folk, there's this curiosity around like, oh, there's a secret, and like, who doesn't want to know a secret? But like, this is none of your business, and like, not a thing you should be asking, right? And then just provider discomfort in treating trans folks in general, especially when it's like, oh, I've never met a trans person. And now I'm faced with, I now need to like treat this person, ask this person like really sensitive questions in a way that isn't going to make them feel ostracized and othered. Yeah. And so when we think about like all of these things are at play, like in this moment between the doctor and patient, right? Between the moment a patient walks to the hospital, The moment a person calls a clinic to make an appointment, right? Like at all these levels, like all these things are part of the encounter that make it really hard for us to like go and seek care and know that, and even when we do, to know that that care is going to be appropriate and like fulfilling and feel like loving and nice as like care should ideally feel. Next slide. Cool. So because the group's so small, we're just gonna stay in this group. Unless, how many of us are there? 8? Actually, to me, breaking up into 4 and 4 might be nice.
Yeah, let me stop the.
So what's gonna happen now is we're sort of similar to the with the Joanna Jacobs case. We're gonna go through the two other cases, and you're gonna go through it in your small groups for the next, like, let's see what time it is. We'll say like 15 to 20 minutes. I'll be in a group, so I'll like keep a pulse about how things are going. And then once that, we'll come back and just sort of like do like a general share of like how that was, like what our thoughts were. And then we're gonna conclude with just like future directions, right? Like how do we think about care, like the care we want to give to our future patients moving forward? And like globally, how do we think about how can we make medicine less of a gatekeeper for queer and trans folks and more of a place where queer and trans folks can come to feel affirmed and validated and supported? Okay. So I'll have us like go through each case and just talk about like just like share outs, like thoughts, what things came up, what like was like really struck you as you were talking about this in your group. We'll start with case 2 with Stan Ellen. Mm-hmm.
Well, Essie already knows what we talked about, but we talked a lot about like the underlying health conditions. Are those disqualifying for a top surgery? Are those actual health conditions that we would actually need to be concerned about, or are they more like cosmetic or just excuses for reasons to not make the decision to do that? And at the end of the day, whose decision is it? Who gets to decide? Why is it one person, one surgeon's decision to go forward with the surgery or not? And is that fair? And I came to the like that I don't think that's fair, that it's one surgeon's decision if the surgery is going to happen that the patient wants.
Another group?
We talked about that too, that question of how are we thinking about these other potential health issues. And I think the question we were kind of focusing on was one of the smoking history, and more so, does that increase your risk for, any surgery? Yes, I think when you have a PAC history of that to that degree, but to your point of, whose decision ultimately should it be? Yeah, I don't think it needs to be just one person.
And something that, thanks for that, Sarah. So one of the things that I brought up when I was talking to Abby about this was, if Stan was smoking this 1 pack per day, right? Like, where was the conversation about how that affects the surgery and like the aftercare, and like maybe we shouldn't do this right now, but like let's keep talking, and maybe let's talk again in like a month, and like here's resources that I can provide to like make the surgery safer, right? Like if that's what he's gonna choose, right? If he's gonna choose like this, I don't think we should do. Let's provide context. Let's like go on this journey to get you to a place where I think it would be safer for you to have this, right? Like where was the discussion about here's why I don't want to do it, right? Like for all of these reasons, right? and right, and that didn't really happen, right? And in terms of the like suicidal ideation, right, there is research even now that says that like folks that get gender affirming procedures, their mental health is usually better afterwards because they don't feel as awful and don't feel as dysphoric. And so some SI, I feel like, especially if like if there was no plan, right? If there was no history of suicide attempt, right? Like if there was no like extensive suicidal history, I don't know if I'd be that concerned.
Right, yeah, if it's a history of passive suicidal ideation, you know, especially if they've got major depressive disorder, it's not, you know, it's not that uncommon. So if the major depression is well controlled, the suicidal ideation should as well. But I also thought it interesting that that Stan didn't talk about gender issues at all with the therapist. So I was wondering if the therapist even knew that Stan was looking at some surgery.
Yeah, so it really depends on what you're going in for therapy for, right? Like, I feel like, and this is something I mentioned to Abby, right? I'm a therapist. Like, we don't all talk about my transness. We're always talking about like childhood trauma, which I feel like is like a super common thing, right? And so like, if transness can like anything, right? It just not come up, right? Maybe my blackness doesn't really often come up either, right? And so I feel like it actually, to me, does not at all really surprise me that didn't come up. If it's not something I feel like things in therapy that come up often are things you're grappling with. And if Stan was really comfortable in this is how I identify.
Right. But, you know, if Stan knows that they need to be signed off on with the, you know, by a therapist to say, yeah, they need the surgery, then it seems like some sort of conversation would be had.
Maybe at some point, right? But Stan maybe just didn't bring it up or like change their mind, right? Like somehow like folks just like today, like, oh, I thought I didn't want this and actually now I do. And so maybe that's what happened, right? Like it wasn't really in Stan's purview at the time, right? Because we're allowed to change our minds, right? Yeah, especially in the context of like leaving your, like having this falling out with your family, right? Like maybe you're like in a different place in terms of like, okay, this is actually what I want. Before I was thinking about like what was going to be okay with this like familial dynamic that I was living in. How did folks feel about the criteria?
I mean, we talked about. Oh, go ahead.
No, I was just saying I don't want to be the only one to talk because I could talk all day.
Yeah, we talked about just how vague and subjective a lot of it is, and how, like, how do you even, what does persistent mean? Who's doing the documentation? What is capacity? And yeah, I think like just for the last part with the significant medical or mental health concerns, like they're told that they need more social stability and support and more stabilized depression, but what does that mean? Just what does that mean about everything, I think is the general question.
Yeah, that's really important. And then moving to case 3, just for the sake of time, are folks cool if we go to maybe like 8:05? And we started like a few minutes. I just want to give ourselves enough time to talk about case 3 and then just talk like really briefly about like future, like what does this mean for the future, right? So for case 3, if you were, I'm really thinking, I think Abby and I talked the most about the second and third questions, but like, how would y'all have discussed this with Ellie? Like, what would you have said? What would you have advised her of? Like, how would you have dealt with the situation?
Bonnie had brought up some really good points about just directing them to, sorry, I don't know if that was the right pronoun for them, but directing them to alternatives for estrogen, like Howard Brown, you know, some trusted providers that would be able to provide them with the right, you know, yeah, with what they did, as opposed to them, you know, receiving it off the street, which it would just not be as safe of an option. Is that the right question, by the way? Sorry, I'm like on my phone. Was that the right?
Oh yeah, yeah.
Okay, perfect.
Yeah, that's actually, it's a really good point about bringing resources. I think Abby and I did not talk about that. I feel like Abby and I were like, yeah, so if she's gonna get on the street, I like pose the question of like, I'm gonna provide as much information as I can to attempt to like mitigate as much damage. If that's something she's gonna choose to do for herself, I feel like I still should provide any information I can to like, for it to be safer. Like, maybe don't take all of it at once. Like, maybe take and
yeah, don't say no, don't do that, you can't have it, but try to make sure that there are safe options for her to access it.
Right, yeah. And how do we feel about, in terms of this affecting her job? Right, because Ellie's coming in, she's concerned that like this is gonna affect her promotion and maybe even lose her job, right? And like legally, depending on where you are, it might be totally fine for them to fire you if they feel like,
yeah, Illinois is an at-will state, which means they can fire you for no reason.
Yeah.
And would she have enough of a case to retain an attorney, and would the attorney be willing to go up against a giant like Victoria's Secret? And would she want to put herself out there like that?
Absolutely.
Because it would all be in the public record, and it's a lot.
And if she loses her job, how is she finding another one? If she, let's say she didn't go to college, she doesn't only has her high school diploma, and she's now in this place where she can't pass as a woman. Who's gonna hire her? And it really puts I feel like this really shines the light on like the issues like within like our own healthcare system, right? Is that like we just aren't looking out for people in ways that
right.
are sustainable.
Only
right?
people with jobs deserve any sort of health care.
And in this case, right, how would this have played out? Or how would, maybe not us, but how would my other healthcare providers feel about this situation? If instead of Victoria's Secret, Ellie was a sex worker, I was worried that her like physical changes were gonna make her less like impact her income. Right? Like if she's working as a cam girl and now her like
right, yeah, and they definitely wouldn't have health insurance.
Right, yeah.
And especially if she makes just enough to not qualify for Medicaid. Would she be able to afford the healthcare marketplace?
Right, yep. Yeah, so thanks for all the contributions. So yeah, the point of the case was really to like get us thinking about like how these things can really like show up in real life with patients and how it can have really huge effects on people's lives, right? It can have this like domino effect, and we're sort of the people that are standing there being like, I get to decide what's going to happen, right? And like how much we know what the policies are in our organizations, right? Like what the overarching like societal ideas about the thing is, all impact what we're going to choose to do in that moment that can have huge effects on queer and trans people's lives. Yeah. So what is that? So as we were thinking about I don't think there's like a concluding slide. I'm just looking. Yeah, no. So yeah, it's fine. yeah, so like, what does this mean for the future, right? Like, how do we as healthcare providers like function less as gatekeepers and like more as people that are there to empower and advocate for our queer and trans patients, right? Like, how can we reduce? And one of the things I brought up with Abby, right, like, was we talk a lot about what's it called? When we talked about the smoking, we talked about the BMI of Stan, right? We talk about all these issues, right? But like, why are we not talking about it in terms of like, okay, there's an increased risk with obesity. How do we mitigate that risk aside from saying no, right? How do we make that surgery safer, right? Stan is smoking a pack a day. How do we think about making surgery safer for folks who smoke, right? Folks are gonna need it. Like, there's someone right now who needs emergent surgery who smokes, right? Like, so it's like, how do we reframe the onus away from the patient and put it back onto ourselves, right? And onto medicine and onto healthcare to make space for the fact that people are trying to live their lives, right? Like, maybe Stan's BMI is really high just because they're super dysphoric all the time. They're super depressed. They were in this really awful family situation. Maybe that's just kind of like how, maybe they eat super healthy and exercise all the time, but it's just nothing changes. That's just sort of how their body is, right? Because like fat phobia is just sort of like a thing that for me it's kind of everywhere, including medicine, right? I feel like, at least for me, one of my answers, right, is when I think about the future is how do I make fewer things about what a patient does and more about how smart and how creative I am and how I'm going to treat them, right? How can I change what I'm going to do so I can make it as safe as possible for someone who does not fall into these categories that we've deemed or maybe are riskier for a procedure, for an intervention, for a drug.
So to try to frame it less as what's wrong with you that we can fix and more like, what is it that you want so you can live your best life?
Yeah. And I think that's the ultimate question we should be asking as healthcare providers, right? Is how can I work alongside my patient to get them to what they want, right? And that, I feel like right now, especially because of how medicine has been like this, like how we've come from this like paternalistic role sort of figure, right? To how we can be more in collaboration with our patients to make space for them to be human, right?
Because we work for them. It's not the other way around.
Yeah, do you folks have any questions? Thanks so much for everyone being here. I really appreciate y'all's time. Listening, we talk about things.
Thank you, Essie.
Yeah, no problem.
I have to take off, but this was awesome as always.
Thanks so much, Sarah.
Bye.
I look forward to hearing the first hour. I had a therapy session with a client, so I missed that. And then the second one canceled, so that's why I was able to catch the last half. So I'm very happy.
That happens, yeah. Thanks so much for being here, Bonnie. I really appreciate it.
Yeah, thanks everyone.
Thank you so much, Essie and Maya.
Yeah, we'll post the recording soon. Thank you so much, Essie.
You're welcome.
Will there be another presentation in the future, Essie?
Of this specifically? Probably at some point. I think I'd really like to do a deeper dive with like a different skew. Yeah, I think there's, yeah. Especially, and I was sort of referring to this with Abby. I'm doing some research in this area, and so it'd be cool to sort of pull in some of that into this presentation too.